Okay, perfect. Here we go. All right, so you've seen some of this material before, but there is maternal morbidity and obstetrics and disparities related to those. So the figure on the left shows the increasing rate of maternal morbidity, plus or minus blood transfusion since 1993 to 2014. And then the figure on the right, on the left-hand side, you'll see deliveries that have no severe maternal morbidity and by race, and then deliveries that do on the right. And essentially, when you look at white women, they're more likely to have, disproportionately more likely to have deliveries without morbidity. And if you look at the green on the bottom, the Black women, they are more likely to have deliveries that include severe maternal morbidity. Similar findings are existing for us with maternal mortality. And I think really this paper in The Lancet in 2016 highlighted that while the mortality was increasing in the United States, in similar countries around the world, it was actually decreasing. And the figure on the left, or sorry, on the right, shows data from 2018 and 2019, which is a bit discouraging because we have now been talking about addressing maternal mortality and trying to find ways to improve upon what we're doing. But even the most recent data show that not only is maternal mortality continuing to increase, but the disparities are continuing to increase. So the question I was asked to address is, what do we do about this? So the answer has often been, for us, for those of us who do clinical research, randomized clinical trials. Randomized clinical trials are great. The pros are that they're the gold standard. So it limits bias in selection. You have a group of women that are enrolled in the studies. And so at baseline, they should have similar characteristics. So you can directly compare between these two groups. And you can establish causation at the end of a clinical trial. The cons to this are that there are very strict inclusion criteria, which does limit generalizability in just about every clinical trial that's conducted. At the end of that, the question is this generalizable to the rest of the population? So kind of historically, clinical trials and pregnant people have been performed in kind of one of two capacities. And interestingly, even in 2021, speaking with very kind of knowledgeable adults, people assume that pregnant people are and should be excluded from clinical trials. So the first category is one in which I'm most familiar with and most involved with, and those are interventions to improve pregnancy outcomes that are specifically related to pregnancy. So for instance, preterm birth, preeclampsia, or even cholestasis of pregnancy or pregnancy-related conditions. And for those, we often will perform clinical trials to try to find the best solution. The area which has been more challenging for pregnant people in terms of inclusion in clinical trials are interventions for common comorbidities that will coexist with pregnancy. So for instance, things like hypertension, diabetes, and even the prototype COVID-19. And we can see how that has played out within our societies. So how do we perform clinical trials in obstetrics? There are a couple of mechanisms. Probably the most common would be an investigator-initiated study where the investigator goes to NIH or some other government funding or industry to conduct a clinical trial. Now, there are many reasons perhaps that industry is disincentivized from doing clinical trials in pregnancy, but that's also kind of beyond the scope of my talk. There are contracts that are submitted or RFAs that are released for contracts for studies such as fetal growth or some other studies that groups are doing, and then they solicit centers. So that's another way to do clinical trials. And then the NICHD MFMU, which you've heard about, which is the only obstetric clinical trials research network. And so I do think that it deserves some more mention. So the origins of the MFMU is that it's focused on obstetrical management. So especially for high-risk patients. And previously, practice had been adopted without objective evaluation, again, because of inherent hesitancy to perform trials during pregnancy. So to address the needs of these well-designed clinical trials, maternal and fetal medicine, NICHD established the MFMU in 1986, which is now 35 years ago. What does it look like today? There are 12 university-based academic medical centers. Again, it's the only federally funded obstetric clinical trials research network, which I think needs to change. The MFMU network conducts clinical studies to improve maternal, fetal, and neonatal health, with greatest priority given to what we're talking about today, reducing morbidity, addressing maternal mortality, but also providing rationale for evidence-based, cost-effective obstetric practice. So as an example, I'll give you the story of the pravastatin for the prevention of preeclampsia. So this was actually a pilot study that was proposed by investigators to the Pharmacology Research Units Network, which Dr. Reddy described. And they had, prior to presenting this work to the OPRU, they had ample data from basic science research and animal data showing safety of pravastatin for pregnancy. So they did, the research question that they had was, what are the pharmacokinetic properties and maternal and fetal safety profiles of pravastatin when used as a prophylactic daily treatment in pregnant women who are particularly high risk for preeclampsia? So in this pilot study, they enrolled 10 women in the pravastatin group and 10 in the placebo, really looking at safety and pharmacokinetics. But they had very remarkable findings. So you can see that in the pravastatin group, there were no cases of preeclampsia, whereas they were all in the placebo group of about 40%. Small numbers, but very remarkable. You can see that the blood pressure was also lower in the pravastatin group overall. And then gestational age at delivery was longer in those who received pravastatin. Interestingly, they also were able to decrease the rate of preterm birth, and this was indicated preterm birth, in the pravastatin group. So very remarkable findings, and a trial to address this major cause of maternal morbidity and mortality in this country and around the world is kind of pending. And so the MFMU is a center that is able to be nimble and to recruit large numbers of women to do clinical trials like this. Another quick example of how the MFMU has changed lives is interesting in that the name of NICHD, the namesake Eunice Kennedy Shriver, is JFK's sister. And JFK's first son, Patrick Bouvier, actually died of respiratory distress in 1963 when he was 35 weeks of gestation. The MFMU also completed a large clinical trial of almost 3,000 women to look at late preterm steroids, which would have helped Eunice Kennedy Shriver's nephew. And trials like this can be done because of the nimble nature of the MFMU and then quickly change clinical practice within obstetrics. And so you can see both the Society for Maternal Fetal Medicine, ACOG, recommended use. And so these are benefits of doing research within the MFMU. But what about other study designs? So I think the take home here is that there's got to be more emphasis on pregnancy and more emphasis on performing different types of studies of pregnant women. I think for too long we've relied on one clinical trials network when really what we need is kind of a large scale and nimble effort. So when you look at the top 3 causes of maternal mortality, and if you look in a textbook or depending on where you're looking, you'll see hemorrhage, preeclampsia, and venous thromboembolism. And you would be correct if you were in 1987. And this is why it's very important to continue these types of epidemiologic studies because things have changed. And so now the top 3 causes are cardiovascular conditions, cardiomyopathy, and sepsis. In fact, here we have recent data from 2014 to 2017 of pregnancy-related deaths in the United States, and you can see how some of the causes of death are changing. And I think it's mainly because we've really implemented different bundles and different initiatives towards hemorrhage and hypertensive disorders of pregnancy, which are now much lower on the list. You can see that we still have now to address these cardiovascular conditions, infections, and sepsis. And so describing the causes of maternal morbidity and mortality are going to be incredibly important in driving the research towards the right areas. And so those types of studies remain incredibly important. Another important piece of information that's been recognized by NICHD is that there are many pregnancy complications in nulliparous women as well. And so there was a discussion about the nulliparous studies in new mom to be. These are incredibly important. And this table just shows you the proportion of morbidities that can occur in someone's first pregnancy. And of course, they're also increased by maternal age. So what are some of the gaps in our current approach? We need to develop other centers that have infrastructure to enroll pregnant women at all risk levels to answer pertinent research questions. It can't only be focused on the high-risk women because there are plenty of complications in low-risk women, and there are more low-risk women than high-risk women. Now, certainly in 2020, 2021, most centers use electronic health records. And there's so much data that's generated there, and we need to be able to gather and analyze these data on a large scale population of pregnant individuals. We need to identify and address barriers to research in underrepresented groups. And I'll speak to that a little bit in a moment. And we need to leverage implementation science. If we have intervention that we think is effective, how is it being distributed to all groups, and how is it studied there? And in fact, it might not be beneficial in different places around the country. We need new alternatives to diversifying our research opportunities. So my next several slides will just talk about what I perceive to be opportunities in research in maternal morbidity and mortality. So we know that this continues to increase. Again, I pointed to the fact that there's only a single obstetric clinical research network with limited funding. So we need more research networks focusing on pregnancy complications. The MFMU is investigator initiated and then vetted by a very learned steering committee. Additional research networks could be formed to rapidly respond to RFAs and study implementation. We also need more studies in rural and community-based settings, which may often not have access to some of the larger clinical trials. I think importantly, for those folks who do clinical research and randomized clinical trials, it's really all about the infrastructure. And so once the infrastructure exists in multiple settings, then the ability to perform clinical trials and to answer questions in a larger variety of settings will be very important. What about clinical research in community settings? So this editorial was actually published in the New England Journal of Medicine about 2 weeks ago. And the group looked at this question and they had some very interesting observations. They commented that community clinicians are often not engaged in research, and that it's the goal, it should be the goal of all of us doing research and of other folks to offer training, mentorship, and access to research for these community physicians, such that they can then encourage their patients to participate in clinical trials. We all know that what a physician or a surgical provider says to the patient is really going to help guide the patient in what they might do. And when they hear it from their own doctor, it's very different than going to a major center and being recruited that way. Leveraging these relationships would really enroll a more diverse population in clinical trials. Lack of trial access, they said, is a particularly problematic barrier for both clinicians and patients. And so this editorial was about increasing diversity in clinical trials, which I think is incredibly timely. Another opportunity we have is expanding traditional mechanisms to allow for follow-up. And I believe Dr. Reddy mentioned this as well. Traditional R01 funding for clinical trials provides 5 years to both study the intervention and then look at outcomes related to that intervention. So it doesn't really allow for long-term follow-up. Once you've recruited all the patients that you need, you probably have only maybe 1 to 2 years or less to then try to have follow-up data. And just thinking of the length of a pregnancy and thinking of the outcomes, you're really limited in what you can do. We also know that maternal mortality is now more frequent in the postpartum period than in the pregnancy period. And so we really need to have mechanisms to allow for longer term follow-up beyond the 6-week postpartum kind of traditional state. We need to study the life course, that is the continuum of pregnancy, postpartum, the fetal programming that occurs during pregnancy, infant and childhood outcomes, and then subsequent pregnancy outcomes. Maintaining prospective cohorts is expensive and something we absolutely need to do. And incorporating detailed pregnancy questions into ongoing pediatric cohorts seems obvious, but is not often done. There are definitely pediatric cohorts that start at age 1 or start at age 5, start at age 18, and all of the details about the interventions that happen during pregnancy and the pregnancy outcomes and whether they were preterm or not preterm really are going to dictate what the cohort looks like. And so those are really important to gather. We need to move beyond the randomized clinical trial, and we need to consider multi-level clinical trials. Multi-level clinical trials can affect at least 2 levels of influence. For example, at the patient and at the healthcare provider, there's usually community input for multi-level clinical trials, and we think that these are very important. You can use economies of scale to study interventions on a target population. And so if we know there's intersectionality that exists, studying more than one intervention also would use economies of scale. The cons are that it does allow for interactions. It makes interpretation of which intervention is leading to the effect we're seeing more challenging. But again, if something is working and it's at a multi-level intervention, then it's still working. And then I think, we've heard a lot about inclusion of women in clinical trials, but I want to maybe focus on including pregnant people in non-obstetric clinical trials, both in clinical, both obstetric, but particularly non-obstetric clinical trials. So the prototype of this was the exclusion of pregnant individuals in the Pfizer and Moderna clinical trials. This, I think, directly led to the September 29 kind of urgent health advisory from the CDC recommending vaccination of pregnant people. In August of this past year, 22 of 161 deaths from COVID and pregnancy occurred, and that was the highest proportion throughout the entire pandemic. We were left with no information on how the vaccine worked in pregnancy. We were asked to make recommendations on the use of the vaccine in pregnancy during a pandemic. And women were not only excluded, pregnant women were not only excluded from these clinical trials, but had to prove that they were not pregnant prior to enrolling in these clinical trials. And so we had no information, and here's where we are today, with essentially a crisis in pregnancy. Chronic medical conditions and pre-existing conditions are 100% related to maternal morbidities and mortality. And interventions to mitigate these chronic medical conditions are not really studied in pregnant people. There are several clinical trials going on outside of pregnancy, outside of institutes that would consider pregnancy as part of their mission, yet these women, when they become pregnant, continue to have these same medical conditions. We've heard this morning. NIH requires that women and underrepresented groups are included in clinical trials. And if I may quote for a moment what they say, women and members of minority groups and their subpopulations must be included in all NIH-funded clinical research unless a clear and compelling rationale and justification establishes to the satisfaction of the relevant institute or center director that inclusion is not appropriate. So exclusion of women, children, and gender race must be justified, but what about exclusion of pregnant people? So there's not a click box or a checkbox or somewhere where you think, should I include pregnant women or should I not include pregnant women? I would wager that pregnant women are different from women in general in more ways than just the size of their uteri. And so it's really important to maybe think about why we're excluding pregnant women, even after PregLac, even after everything that we've said about how important it is to study interventions in pregnancy. Why is it important to include this pregnant person from this clinical trial? Is it paternalistic? Is it historic? Or is there an actual justification? Studying non-obstetric interventions in pregnancy. Once exclusion of pregnant people is considered, then it would facilitate studying non-pregnancy interventions in pregnancy. For instance, behavioral interventions, mental health strategies, technologies that are, again, studied widely, but there was never a consideration to even including pregnant people. What ultimately ends up happening is then we have to then replicate the findings in pregnant populations and use the clinical trial networks that we have to then say, well, does this also work in pregnancy? And certainly with economies of scale, with the expertise we have, not only in this forum, but worldwide, really, in studying pregnancy, we can include pregnant people in all of these clinical trials and ask the pertinent questions for pregnancy. It's really the ethically correct solution. And again, I spoke about EHR data as really a low-hanging fruit because pregnancy data is generated copiously in the electronic health record. Coordination of this effort really should be at a national level. It's as simple as having common variables and having a variable dictionary such that everyone can ask and answer the same questions of patients. Even in a single institution, things are named differently across either different EHRs or inpatient versus outpatient. And so having a language that we all speak so that we can leverage this data is going to be really important. Epidemiologic data to identify morbidities, outcomes of newly introduced interventions, and implementation barriers is is important, and I think it's one of the simpler in theory ways of being able to gather really important data. We can also leverage EHRs to collect data on underrepresented groups and those less likely to be involved in clinical trials, either because of access to these trials or desire to be enrolled in them. So in conclusion, there are numerous opportunities to study maternal morbidity and mortality. We need to move beyond the single clinical research network in obstetrics and include broader groups that have the infrastructure and are nimble and ready to study what is thought to be clinically relevant questions. We need to allow for follow-up and life course evaluations in our current time-limited mechanisms. We need to leverage EHR data, and I would say we absolutely need to start justifying exclusion of pregnant people in clinical trials. So thank you so much for your attention.